Amy, just want to confirm that you can hear me. And then
Now, yes, now I can. Thank you.
we are going to be doing slides, so I'm going to go ahead. Once I take down our housekeeping slide, I'll make you the presenter.
Okay, so do you want, like, I put a BHIP slide in there, but should I not talk about that because you're going or
It's up to you. Lily's going to facilitate. We just have a housekeeping slide that gives kind of like a little overview of reminders. I will pull it up now, but Lily
okay,
will give a little introduction.
okay.
Let me just share. Just look how it should.
Yes.
Welcome to those of you that are joining us. We'll get started in just a few minutes. In the meantime, please feel free to introduce yourselves in the chat. Just make sure you select everyone when you use the chat function. We also have this housekeeping slide up with just a few things to remember. So please feel free to read that as we wait for others to join us. Okay, it looks like it is 12 o'clock, so we will get started. Welcome everyone and thank you for joining. My name is Lily Stavisky and I'm a part of the BHIPP team. I will be introducing our presenters for today and facilitating our Q&A at the end of the session. Just a few things to remember is that cameras and microphones are disabled. Please use the chat function for questions, comments, and any support. Be sure to select everyone from the drop-down when typing into the chat. There will be 15 minutes for Q&A at the end of the presentation. If you are participating today to receive CME or CEU credit, you will need to attend for 45 minutes or more to receive your certificate, and all participants who would like to receive credit will need to complete the evaluation survey at the end of the session, which will be placed in the chat. CME and CEU certificates will be sent out in 3 business days, and the full recording of today's session, the slides and related resources will be posted to our website next week. For those of you that are unfamiliar with BHIPP, I would just like to provide some information about our program. Maryland Behavioral Health Integration and Pediatric Primary Care, or BHIPP, is a child psychiatry access program that supports the ability of pediatric primary care providers and emergency professionals to address and manage mental health concerns. BHIPP is a free statewide program that offers telephone consultation, resource and referral networking, care coordination, telepsychiatry, telecounseling, and training and educational opportunities. The BHIPP warm line is staffed by a team of child mental health specialists and is available Monday through Friday from 9 a.m. to 5 p.m. And our phone number and website will be placed in the chat for you. It is my pleasure to introduce today's BHIPP Resilience Break, Treatment of ADHD in Young Children, presented by Dr. Amy Benincourt and Dr. Mark Riddle. Dr. Amy Benincourt received her PhD in clinical child psychology in 2010 from Virginia Commonwealth University and completed a postdoctoral fellowship in prevention science in the Johns Hopkins Bloomberg School of Public Health. Dr. Benincourt is a clinical child psychologist and assistant professor in the Johns Hopkins School of Medicine Department of Psychiatry and Behavioral Sciences, with joint faculty appointments in the Johns Hopkins Bloomberg School of Public Health and the Johns Hopkins School of Nursing, and she is also the Director of Research and Evaluation for BHIPP. Dr. Mark Riddle is a professor of psychiatry and pediatrics at Johns Hopkins University School of Medicine and former director of the Division of Child and Adolescent Psychiatry. His current clinical work involves providing phone consultations to primary care clinicians. The focus of Dr. Riddle's research, teaching, and clinical practice is pediatric psychopharmacology, especially medication side effects. His publications include over 300 research articles, reviews, chapters, and edited volumes, including Pediatric Psychopharmacology for Primary Care, published by the American Academy of Pediatrics. We are very grateful to have you both here today. Thank you for sharing your expertise with us during this session, and I will hand it over to you guys.
Awesome. Thank you, Lily. Can everybody hear me okay? Got to do my first check of that. All right, I'm going to go ahead and pull up our slides for the day. Okay, so as Lily mentioned, we're going to be here to talk to you today about the treatment of ADHD in young children. And let's see if Lily's already talked about BHIPP, so I won't go over this again, but here's a lovely picture of what services BHIPP offers. And I also want to give an acknowledgement to our funders and partners. So BHIPP is a partnership between the Maryland Department of Health, Behavioral Health Administration, the University of Maryland School of Medicine, the Johns Hopkins University School of Medicine, Salisbury University, and Morgan State University Schools of Social Work. And we're really grateful to BHA and to HRSA for our funding. And we have no conflicts of interest to disclose. Okay, so now that all that housekeeping is done, we're going to get into the meat of our presentation for today. So by the end of today's talk, you should be able to describe the approach to the assessment of ADHD in young children. And then we're going to spend the bulk of our time really talking about the treatment of ADHD in young children, and that'll include being able to describe the rationale for using behavior management training to treat ADHD, 5 common strategies that are taught in behavior management training programs, and the approach to medication management to treat ADHD in young children. I want to start with a case example. And for those of you who are on here, likely because you work with young kids or are thinking about working with young kids, I'd say this is a pretty common example of things that might come across our clinics where we're thinking about whether ADHD might be in the picture. So this is Zion, not this child's real name. It's a 4-year-old boy who presents to your clinic with the following. He was kicked out of his previous preschool for behavior. He has difficulty listening and following directions. He has difficulty sitting still in his preschool class. He's always getting out of his seat and getting in his peer space. He's had trouble during circle time, kind of staying on the carpet during that. He may experience tantrums or gets aggressive when he's told no or that he can't have something that he wants. He also has a hard time getting himself ready in the morning, despite his parents saying that he definitely knows how to do this. He also has a really hard time with transitions, especially if he has to go from something he really enjoys, like playing with his toys, to transitioning to a less preferred activity like coming to dinner or taking a bath. And Zion doesn't like to share with his younger sibling, and he will become aggressive with her if she tries to play with his toys. So you can see a mixture of things going on here, some difficulties behaviorally, and also some suggestion maybe of difficulties with paying attention. Okay, so I want to just lay a little bit of groundwork about ADHD. So among US children ages 3 to 17, approximately 9.5% have a diagnosis of ADHD. And the diagnoses of ADHD, the proportion of kids or rate of kids who are diagnosed with ADHD increases with age. So it's approximately 2% of children in the 2 to 5-year-old range, climbing up to 9% of children in the kind of school age range, 6 to 11 years old, and then approximately 12% of adolescents. And we know from different data sources that approximately 1/3 of children with ADHD receive that diagnosis before the age of 6. We also know that boys are twice as likely to be diagnosed with ADHD, and increasingly that primary care providers are the most common provider who's making that diagnosis of ADHD. So in thinking about making the diagnosis, I'm going to highlight just a few things that are both some general diagnostic challenges as well as some challenges that are specific to this age range. So the first is that in order to make an ADHD diagnosis, the symptoms need to be present in more than one setting. And now in older kids, this might be a bit easier. This is things like at home and at school, or at home and aftercare, or could be in sports or other extracurriculars. But for younger kids, this can be a bit challenging, especially for kids if they're not involved in some kind of formal daycare or preschool program. So then you would be looking for, are there other settings that are they with other caregivers, and are the symptoms appearing in both of those settings? The second is that many behavioral manifestations of ADHD, like being fidgety, talking a lot, and interrupting, can be normative behaviors in young kids. So we'll talk more about this, but we're really trying to determine if this developmentally normative behavior or developmentally inappropriate behavior. We also know that the symptoms of ADHD, so inattention, hyperactivity, and impulsivity, can also be seen in other disorders. And so, thinking about as you're making your sort of considering your differential diagnosis, there's a broad range of diagnoses that will need to be considered. And there is also no single diagnostic test that confirms the ADHD diagnosis. Also, and I kind of already alluded to this, the ADHD symptoms are not mutually exclusive to other conditions. So things that we have to keep in mind is a broad range of disorders when we're considering this diagnosis. It's also important to consider and not overlook environmental factors that might affect a child's behavior. And this can be things like their experience of trauma or other changes in their kind of day to day, and how those are those indicative of ADHD? Are those indicative of something else? So lots of different factors to keep in mind. And then kind of further, some specific diagnostic challenges related to young kids. So young children just have a smaller range of behaviors than, say, an adolescent, from which we're trying to discern if there's a problem. We also, again, and I kind of already mentioned this, but we really have to be paying attention to the fact that are the difficulties this child is experiencing significantly greater than the child's typical activity level, aggression, or dysregulation that we would expect for their age and developmental level. So having tantrums frequently, if the child is 2, is not necessarily developmentally inappropriate. But if the child is 4 or 5, we might wonder more about if they're having tantrums daily or multiple times a day, should we be thinking, should we be more concerned? Also, we know that the symptoms, as is the case for ADHD at any age, need to be present for more than 6 months. And when you're talking about a young child of 3 or 4 years old, that time frame can present some challenges alongside the rapid developmental changes that we're seeing during the same time period. We also have to think about what are the expectations placed on this child and how are those impairments showing up. And the challenge here is that the expectations placed on a young child may vary by the setting and the individual child. So we need to understand a bit about what is expected of this child at home, in their daycare setting, or in preschool, and then how are they doing with meeting or not meeting those expectations to kind of get a better sense of their impairment. Finally, there are very few symptom rating scales that are validated for use in children under 6. And while a screening tool or a symptom rating scale is only one piece of the puzzle, we know, and I know we frequently rely on and appreciate the use of the Vanderbilt when we're diagnosing ADHD in older children, for example. But there are, as I mentioned, very few rating scales that are appropriate for this age group. So this statement comes from the AAP Clinical Practice Guidelines for the diagnosis, evaluation, and treatment of ADHD in children and adolescents. And I think it helps punctuate the key things that we need to keep in mind in our assessment of what a young child is experiencing. So if a child presents with symptoms of developmentally inappropriate levels of inattention or hyperactivity and impulsivity that are present for more than 6 months across multiple settings and they impair functioning, then it's appropriate to treat the ADHD if the history and physical examination do not point to another diagnosis. And I want to kind of accentuate that last point. So we have to keep in mind the differential diagnoses for ADHD. This can include behavioral disorders like oppositional defiant disorder, developmental disorders like autism, and specific language disorders, medical disorders like a hearing impairment, and other psychiatric disorders that can contribute to similar symptoms like anxiety, for example. So we have to consider a number of different things. So with that, we just wanted to kind of set the stage first about some things that you need to keep in mind about approaching the diagnosis of ADHD in young children. But now we're going to shift and spend the bulk of our time really talking about the treatment of young kids. And so if you think back to Zion, who's having difficulty with transitions, difficulty with aggression towards others, with sharing, kind of staying in a seat, participating in preschool. The approach that I'm going to talk about first is behavior management. And we're going to talk about how to kind of keep Zion or similar kids that you might encounter in your practices in mind as we're kind of walking through and talking about these strategies. So behavior management training is a treatment modality for improving adult-child relationships and reducing behavior problems that are common in young children, like non-compliance, tantrums, and aggression. And this intervention can be used both to prevent as well as treat child behavior problems. And it's based on the underlying assumption that adults can be taught to be the change agents for children's behavioral difficulties by changing their own behaviors. And behavior management programs can be helpful for both shaping behaviors at home as well as in educational settings. But for the purposes of the rest of this talk, I'm going to primarily focus on a specific type of behavior management training treatment called parent management training or behavioral parent training. It has a number of different names. So most of the examples that I'll be giving will be in the context of the parent-child relationship. But keep in mind that these can be helpful in managing behaviors anywhere where there's an adult in charge who can kind of use these strategies to promote the child's health and well-being and manage behaviors. So research shows pretty consistently that behavior management training is effective in improving child conduct problems, parental mental health, and parenting skills in the short term. And it really is the first line treatment for young children with ADHD. I'm going to talk just briefly about the PAT study, and Dr. Riddle will get more into this a little bit later when we're talking about medication management. But the PAT study was a multi-site randomized control trial to evaluate the use of methylphenidate in preschoolers with ADHD. I mention this because a time-limited trial of parent training was required before preschoolers were entered into the medication phase of that study. And the parent training included 10 weekly 2-hour group sessions with trained clinicians and focused on a number of the strategies similar to what we're going to be talking about today. So just to further highlight that really behavior management training should be the first line treatment when we're considering ADHD in young children. Behavior management training programs are guided by social learning theory. And this theory posits that adults are powerful models and reinforcers of children's behavior, both positive and negative. And within this theory is a specific model called the coercive process model, which suggests that adults and children unknowingly reinforce the wrong behaviors in one another. So let's take a common example where a child has a tantrum in preschool when they're asked to transition to reading time. In response, the child is taken out of the classroom and therefore misses the reading activity that they didn't want to do anyway. So we've just reinforced this child to tantrum in order to get out of doing things that they do not want to do, which is obviously the opposite of what we're hoping to achieve here. The other side of this is that children inadvertently reinforce undesired behaviors in adults. So take another common example where a child does not put her toys away after the parent has asked her multiple times to do so. The situation now escalates and the parent is threatening the child with a spanking and the child puts her toys away. So the child has just reinforced the parent to escalate the consequences in order to get her to comply with the parent's instructions. But part of what behavior management training programs do is they can help adults to stop this cycle through the skillful use of their attention, behavior, words, and affect. And so that's where various parent training programs or behavior management programs really come in. So we're going to talk about some of those specifics. Now, there are literally hundreds of evidence-based behavior management programs for parents. They're all based on a similar underlying theory and cover strategies that are focused on positive reinforcement to strengthen the adult-child relationship, as well as limit-setting skills for implementing consequences and setting boundaries around children's behavior. And many also include a focus on problem-solving skills, managing adults' own stress, because we know that stress can get in the way of adults using the strategies that we know are effective for managing children's behavior. And most of these programs include some kind of practice assignment, with the idea that behavior doesn't change just by coming to the meeting. So really the important piece, one of the active ingredients, is that parents go home or leave the session and try out the strategies with their children and come back and talk about how that's going, and further problem solving kind of happens at that point. These programs really focus first on strengthening the parent-child or the adult-child relationship, and then tackle later addressing more of the sort of limit-setting strategies. And the thing that can sometimes feel interesting about this is that the people coming to you for help really want help with the discipline, with the misbehaviors. And then you're turning to them and saying, we're going to first talk about the ways that you spend time with your child and the routines that you have in your house. But the thinking here is that if parents start to give more attention to the behaviors they want to see more of, this should tip the scale some. It's not perfect, and we're still going to have to spend time managing misbehaviors, but the thinking is to lay this groundwork first with really focusing on positive reinforcement. So here's just a quick slide to show some different examples of parenting skills programs by format. One of the most common individualized parenting skills program is called PCIT, or Parent-Child Interaction Therapy, which is a parent-child coaching model. There are also a number of common group-based parent training programs like the Chicago Parent Program or the Incredible Years Program. And there are increasingly kind of digital adaptations of these that can be self-administered, like through a tablet or virtually in some other way, so that parents can kind of take this material in at their own pace. So now we're going to dig a bit into some of the strategies that are taught in these programs. I'm going to give you examples of 4 common strategies for strengthening the adult-child relationship first, and then we'll talk about some strategies for limit setting in a little bit. The first strategy is child-centered time. This is the time that parents spend with their kids, focus on what the child wants to do. During this time, parents follow their child's lead, letting the child pick the activity, and letting the child decide how they're going to do that activity together. This is also sometimes referred to as one-on-one time, and it helps the parent-child relationship because it reduces the chances that children will use negative behavior to get their parents' attention, because they're getting this sort of proactive, positive attention from their parents. But it also promotes feelings of warmth and love and a positive sense of self in the child. And, depending on the child and the family, if we're spending a whole lot of time being frustrated and managing a lot of difficult behaviors, what can get lost in that is really taking the time to enjoy each other's company. And so this one-on-one time or this child-centered time can kind of bring back that focus on really enjoying playing together or going for a walk or any very simple activities that families do every day can be child-centered. But this is really helpful in kind of being intentional, building that time in every day. A related strategy to child-centered time is what's called descriptive commenting. This is a strategy in which the parent describes what the child is doing. They're basically acting like a sports announcer for their child's actions. And this is a useful way for parents to teach their children new things, but without controlling the interaction or overwhelming their child with questions and instructions. It's also just a nice way to say, I'm paying attention. I'm really noticing what you're doing right now. We also can encourage parents to use descriptive commenting to label children's feelings. And part of what this does, if a parent says, I can tell that you're really happy right now, or it seems like you're really enjoying playing with your toys. You're helping the child kind of connect the feeling that they're experiencing internally with the words that go with that feeling. And that can also help, especially for kids who might be struggling with kind of making sense what they're feeling. This can help them to feel seen and validated. Another strategy that was kind of covered in this sort of positive reinforcement vein is around establishing routines. And routines are behaviors that are regularly practiced, such as brushing teeth in the morning, taking a bath at night, or reading with your child before bed. And routines help children to feel safe and in control of their world because it helps them to know what to expect next. It promotes a predictability, and routines can also decrease anxiety and behavior problems for the same reason. And they can also help children who may have executive functioning difficulties and struggle to remember the order of events. If the order of events stays the same, this really will promote some self-confidence and competence in kind of getting through those routines. Another important strategy that's taught as part of positive reinforcement is praise. And so we know that any attention, positive or negative, will reinforce a child's behavior. And so it's important to help parents understand that they can use their attention strategically to encourage positive behaviors they want to see more of. So we often use the phrase, if you want to see a behavior again, give it your attention. And so praise helps because it gives attention to specific desired behaviors. It also builds children's self-esteem and self-confidence and increases the chances that the children will want to repeat that desired behavior. But we have to be careful not to mix our praise with criticism. So, I love it when you make your bed. Why can't you make your bed every morning? Leaves the child thinking what they did wrong rather than focusing on the fact that they were just praised for making their bed. We also want to make sure that we're praising kids for both their effort and the outcome, right? So I really appreciate how hard you worked to clean up your toys when I asked you to, versus just, I thank you so much for cleaning up your toys, because you really want to acknowledge that there's a process and effort that the child is putting in. There are two types of praise. There's labeled praise and unlabeled praise. Both are good. One is slightly better than the other. So labeled praise is positive statements that identify the specific behavior the child is doing or did that the parent likes. For example, I love how hard you're working to clean up your toys, or I love it when you help me in the kitchen, or I love it when you go get ready for your bath when I ask you to, any of those things, right? Unlabeled praise are also positive statements, but they're general. Good job. You're such a nice boy, or nice work. They don't take much thought on our part as the adults, but it's also less clear to the child what it is that we like. And so that it's less clear what they're going to try to repeat to get that praise again. The last strategy that I want to talk about in the context of this sort of positive reinforcement piece is the use of reward programs. So sometimes there are behaviors that are challenging for children to change, and that praise alone is not enough. These might be things like staying in bed all night, helping with cleanup, getting themselves dressed in the morning. And we, especially in the context of ADHD, we know that getting through those morning routines and getting through those evening routines can be particularly challenging. And so this might be a place where a reward program is helpful. But to be effective, reward programs need to be clear, they need to be simple, age appropriate, and ones that the adult is going to consistently be able to follow through on. Because where a reward program fails is if a child does the desired behavior and the adult forgets to acknowledge and reward them for doing it. Then children will become suspicious and really not have much buy-in into the reward program. And rewards can be both material rewards, like for young kids, these could be stickers and prizes, but rewards can also be social rewards, like extra time with the parent or getting to stay up a little bit later, getting an extra story before bed, things like that. So they just does not have to be complicated. And reward programs help because they focus the parent's attention and the child's attention specifically on the behavior that they're wanting the child to master. And so I mentioned some examples like staying in bed or helping with cleanup, but you can also have other examples around toilet training, reducing aggression, or really there's a whole range. But the point here is not to get into a reward program if something simpler will work, because reward programs require more of the adults. But they also carry that extra emphasis of acknowledging to the child that the adult is aware that the behavior is hard for them to do. And this can be helpful in the context of ADHD where where you're providing more external motivation for the child to work on these behaviors that may be challenging for them. Okay, so now I want to turn to some strategies that help parents to effectively set limits on children's misbehaviors. So the first of these is the use of do statements. And so one thing that we're often talking with parents about is this idea that, I'm asking my child to do things and I have to repeat myself and repeat myself and repeat myself, and they're not following directions. And so one of the first things that you want to ask them about is, how are you communicating those expectations to your child? How clear are you being in what's needed? Kind of what else is going on? So if I'm yelling across the house to my child that they need to pick up their toys, and my child has ADHD, I'm not sure if they were paying attention to me. So I want to make sure that when I'm asking my child to do something, I have their eye contact and as much of their attention as I possibly can. But then the second piece of it is what I say. So some colleagues of mine in the Johns Hopkins School of Nursing observed hundreds of parents playing with their 2, 3, and 4-year-old children, each for about 15 minutes. And what they found was that during these 15-minute free play sessions, the average number of instructions that parents gave their children is 64. That's the average, which means that's 4 instructions a minute. And it's literally impossible for children to follow through with so many instructions. And surely no parent can follow through on those instructions either. As a result, many children learn to either tune their parents out and to ignore those instructions until parents yell or escalate the situation. But some children, those who are less regulated, cannot tune their parents out, and instead they become anxious, overwhelmed, and potentially destructive. So for these reasons, it's important to help parents reduce the number of instructions that they're giving to only those that are really important, and then to be really clear in those instructions that they give, and then be prepared to follow through on their expectations if the child doesn't comply. And we'll talk about consequences in a minute, which is that follow through piece. So part of this is through the use of do statements. Do statements are brief and clear statements that communicate to the child what it is that the parent wants them to do. And they do not communicate that the instruction is optional. So these are things like put your coat on, put your toys away, turn off the TV. But what happens a lot is that we give a lot of unclear instructions or unclear commands. Probably the most common is question commands. We think we're being polite when we say things like, could you put your toys away? Or would you mind helping me with this? But what the child hears is that you're asking them a question so that they could say no. So if I say, could you put your toys away? Most children who are having a ball are going to say no. And then what do you do? So we work with parents to learn that they can be respectful in their instructions, but also not be giving children options when they don't intend to. The other really common one is negative commands, where we tell children, don't leave your toys out, don't run. So we've told them lots of things that they're not supposed to do, but we leave them unclear about what it is that we want them to do. So really, this is where we go back to those do statements. Kind of building from there is this idea of logical consequences. So Logical consequences describe what the parent will do if the child continues a particular misbehavior. And that misbehavior could be aggression, could be non-compliance with something the parent is asking them to do, could be a whole range of things. But these if-then statements, so they really need to include consequences that are logically consistent with the misbehavior, that are as close in time to the misbehavior occurring as possible, and that are age appropriate. So, for example, if you don't eat dinner, you won't get dessert. It is what will happen if the parent intervenes after the child refuses to eat dinner. Now, an illogical one would be, if you don't eat your dinner tonight, you can't have dessert for the next 2 weeks. First of all, a 4-year-old child is not going to remember tomorrow, let alone 2 weeks from now, but it's important to really keep the developmental level of the child in mind. But the other key here is that the adult has to follow through on the consequence if the child chooses to persist with the behavior. So a couple other examples. If you color on the table, then I will take the crayons away. If you two keep fighting, then you'll both have to go to the office, or maybe at home, this would be you both would have to take a timeout. So these are the limit setting strategies. You're giving the child a warning of what will happen if they continue persisting with their misbehavior, but it also gives them a choice. So if they continue, then the consequence will be whatever the parent has laid out. But they also can choose to stop the misbehavior, and there is no consequence. And so it reduces adults from kind of yelling and nagging at their children, and instead just being clear, calm in setting those limits with children. Sort of a partner strategy to this is something we call when-then statements. These are statements that tell children what they must do in order to get something that the child wants. And then it's still in their hands. If they choose to comply, then they can get the desired thing. And if they choose not to, then they won't. So sometimes we refer to these as win-wins because the parent wants the child to do something and the child wants something. So it's like a mini reward program. So when you clean up your toys, then you can have a snack. Or when you finish your homework, you can go outside. When you say please, then I will help you. So these also keep parents from yelling and nagging and using threats or punishment in order to get children to comply with instructions. And they help children really take responsibility for their actions. 2 more strategies that I want to talk about. The first, and probably one of my favorite strategies, is active ignoring. So ignoring is the act of not responding to undesired behavior. And this means not talking to, looking at, or responding to the child while the undesired behavior is occurring. And that once that misbehavior stops, the adult needs to give their attention back to the child pretty quickly. It's very easy to describe, right? Just ignore the misbehavior. But it is very challenging to do because often the behaviors that we're asking parents to ignore are annoying behaviors: whining, tantrum, asking repeatedly over and over for the same thing to try to get the parent to give you a different answer. These are all things that could be ignored because they are just done to try to get the parent's attention, but it can be easier said than done. This behavior works because, or this strategy works because it removes the adult's reinforcement of the behavior. But we really have to help parents to think about and reserve these only for misbehaviors that are safe to ignore. So we would not want parents to ignore if a child is running away from them in a public place, or if a child is engaging in destructive behavior like aggression. And the other thing that we have to help parents anticipate is when you first start to ignore a misbehavior, the misbehavior will get worse, or it might get worse because the child is used to getting attention for that misbehavior. So we really have to help parents anticipate that when the behavior is getting a little worse, that actually means that the ignoring is working and that they need to hang in there because it will then in turn get better. The last strategy that I want to talk about is really, I'm borrowing from a program called the Chicago Parent Program here, but really is a way to think about the use of limit setting for children kind of across the board. And this is what's called the 8 keys to effective discipline. And so this is regardless of the discipline strategy that the parent is choosing to use, the things that they need to be keeping in mind. And this, applies to the logical consequences that I was just talking about. Another example of a common discipline strategy that is taught in many parent training programs is the use of timeout. But the idea here is that the discipline needs to be tied to a specific behavior. So the children need to know the specific thing they did wrong and what needs to change. The discipline needs to be safe and age appropriate. So we have to make sure that we're asking, are the expectations of the child's behavior reasonable? And is the goal for them to learn from this discipline? Because we know that harsh punishments that children don't totally understand only make them angry and hopeless and can contribute to behavior getting worse. The discipline also needs to be predictable, meaning that whenever the misbehavior happens, the consequence happens, and not just when the parent's had a bad day or doesn't feel like kind of managing the misbehavior. The discipline also needs to be controlled, so parents should never lose control over what they are saying or doing, and it should be done without rage. They should never lose control over what they are feeling while giving the limit with their child. A discipline should be done without humiliation. So even when children are being disciplined, parents should always respect a child's dignity. And then the last two can be hard when we're feeling, when parents might be feeling frustrated with their children's behavior, but the discipline needs to have a positive ending, meaning that when it's over, it's over. Children need to be allowed to reconnect with their parents in a positive and loving way. And children need to know that they are loved even though the misbehavior is not. And so these keys to effective discipline can be kept in mind for any number of approaches to disciplining children, because the reality is, a parent can kind of yell at their child in a really upsetting way and never, kind of try to escalate the situation further. And so these are really important things to keep in mind. And so timeout is a good example of something that meets these 8 keys to effective discipline, but there are lots of logical consequences that parents could use that would also fit with this. And so with that, I'm going to turn things over to my colleague, Dr. Riddle, to talk about the medication management of ADHD.
Thank you, Amy. So which ADHD medicine to try first? And here I'm talking about school-age children, not preschoolers. And the American Academy of Pediatrics and the American Academy of Child and Adolescent Psychiatry both recommend either methylphenidate or an amphetamine preparation. And then guanfacine, clonidine, or atomoxetine if there are concerns about specific stimulant adverse events or the parent is too concerned about stimulants. Next. So what about methylphenidate versus amphetamine? And this data does not include preschoolers, and it's based on some data and my experience, but I'm just offering it as an opinion. So Adderall, which is mixed amphetamine salts, is the most popular prescription stimulant street drug. Methylphenidate preparations don't get you high, they don't get used. Nobody sells them on the street. Amphetamine reduces craving for cocaine and is used in some treatment programs to assist with cocaine discontinuation. Methylphenidate has no effect. And then I've had personal experience mostly with graduate students who would complain of increased motivation on therapeutic doses of Adderall or Adderall XR. And they didn't like this feeling. With a switch to a methylphenidate preparation, the motivation effect goes away. None have reported this effect on methylphenidate preparations. And that doesn't mean they became unmotivated. They just weren't jazzed up. Next slide. So what ADHD medicine to try first in preschoolers? We don't have much data. The best data we have is from the study that Amy mentioned, the preschool ADHD treatment study, or the PAT study that was done about, how long? 15 years ago it was published. We were part of that study. Next slide. Just some comments before we look closely at this slide. This study was scrutinized like nothing I've ever seen in my career. The White House weighed in and wanted some changes. The FDA did, the DEA did, and the NIH did. And what we as Six Slides started out with is what I think was a really good study, got beaten up pretty badly. Fortunately, the first two parts, the psychotherapy that Amy mentioned, stayed in, and the randomized treatment of each child on 4 different doses and placebo randomly assigned for 1 week stayed in. I'm just going to comment about the therapy. We had 2 very good clinicians doing it. It was small groups. It was a terrific therapy, almost to the family. They said, wow, this has helped us a lot. We're going to take this with us over the longer term. But it didn't get at the core ADHD symptoms enough, the inattention, impulsivity, and hyperactivity. It was sad that the psychologists who did this didn't write it up. They didn't want a negative ADHD study, but I thought, what a fab treatment. After that, the kids were randomized. There were 144 who completed this 5-week random trial. And the outcome, which was done by blind raters and the parental consensus about which of the 5 was best, 85% said methylphenidate, 10% placebo, and 5% there was no response. So we may have gotten the diagnosis wrong in that group. And perhaps most importantly, the mean total daily dose was 14.1 milligrams. So 15 milligrams. And if you're using, say, 5 milligrams of Ritalin, methylphenidate, that would be like 5 milligrams 3 times a day, and that's it for the average effective dose. So low doses. Next slide. And this just shows the dose response where they're lined up by how many milligrams that we used. And you can see it gets better as you get to higher doses. Next slide. Now, what about safety concerns and side effects? Well, appetite decrease, even at these doses, occurred in 50% of the kids. There was more dysphoria than you usually see in school-age kids, 10%. Less insomnia, irritability, and anxiety than you often see. And a few kids had sort of unusual responses. 9% on the high dose talks less with others, 12% uninterested in others. So I think it was making them somewhat robotic, which we usually don't find in older patients until they've been on a high dose for a long time. So we have to be careful about side effects. Next. We then did a 6-year follow-up, and the point of that is that by far the big majority were still in treatment, many on medication, and ADHD that starts early, that is problematic enough that they need this kind of treatment, doesn't disappear. Next slide. Now, this is a very busy slide of stimulant delivery systems. The left column is proper preparations. IR is immediate release, like Ritalin or Focalin or Adderall. A pulse is, there's an immediate release, and then hours later, there's another release. And with my days, which you see in the red on the right, there are 3 releases. I call that medicine no sleep. The next one is the pearls. Those are matrices that are developed by the pharmaceutical companies, and each company has a patent, so we don't know exactly what they are. But they're designed to make the release kind of fit the need, which is highest usually in the afternoon. And then pump is an osmotic pump, and then modified immediate release. Below the bar there are the non-pill preparations. And I'm going to focus on just 2 that are in blue, methylene and Quilivant. That's regular methylphenidate and extended release up to 8 to 12 hours methylphenidate. and both are okayed by the Maryland Behavioral Health Administration for treating young kids with ADHD. So those are the two I always go to, and I think my colleagues do too. Next slide. Then there are the alpha adrenergic agonists, guanfacine and clonidine. You probably know they were developed to treat blood pressure. There are 3 alpha adrenergic receptor subtypes. The one that matters most is the A, the prefrontal attention inhibition memory, not B, pulse and blood pressure, and not C, which is not as well characterized. Guanfacine is specific to the A subtype. Clonidine is non-specific to all of them. So there are more blood pressure pulse changes, somnolence, rebound awakenings, irritability. And so my preference, and I think that of many of my colleagues, is guanfacine. Next slide. And this is the dosing for kids older than 5. So this is for older kids, and you probably know this. Intuniv is the branded extended release, 24-hour effect. You can give it at bedtime, start with 1 milligram, increase by 1 milligram a week, cap-based twice a day, 0.1 milligrams. Next slide. But the major problem in preschoolers is that the guanfacine or Intuniv, it's safe, but its main adverse event is somnolence. So once a day dosing given at bedtime may help sleep onset. Extended release lowers the peak level, thus reducing severe side effects. But guanfacine ER is non-crushable pill, and there's no liquid formulation. So you basically can't use it in preschoolers. Regular guanfacine can be crushed, and I put a capital D there so you remember it, crushed. It's got to be crushed if they're going to use it, and it can be used in half or quarter milligram doses during the day. The problem again is somnolence and other side effects, and another problem is a bit higher peak levels. But when families need this medicine for help and we agree on it, they can make it work in this way. And I'll mention there's a clonidine solution that's fairly new. Just back one, just a minute. There's a clonidine solution that's fairly new, and that's effective if you want to knock a child out. Give them enough of that at bedtime and they're gone. The problem is their sleep will be disrupted when it goes away. And the data shows, and personal experience shows, more insomnia, more fatigue, and more irritability in kids that get that treatment. Next slide. This is a busy slide, but one of the points I wanted to make here is that we are so desperate for data in preschoolers with ADHD that JAMA published this, and it's a chart review. They never publish chart reviews, never, ever, 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 ever. But they published this one because they know we need data. And it was 7 different sites, university sites, behavioral, developmental pediatrics, and these were good clinicians, I think. And here's what they ran into with the alpha adrenergic agonists. If you look at daytime sleepiness, the first one, 38%. Moodiness, 29%, disruptive behavior, 28%, and then it gets better. And with the stimulants, the moodiness and irritability is 50%, so it's not without problems, as is appetite suppression further down. Next slide. So dosing. And here I would consider giving us a call so we can kind of talk it over with you if you're going to do this. And we're getting so many more calls about preschoolers that your colleagues are beginning to do this, and we're helping to make it work. So methylphenidate, you start with a morning dose, add a second dose when it wears off, add a third dose if needed when it wears off. Start with 1 to 2.5 milligrams per dose. Increase or decrease as needed with expected total dose 10 to 30. Remember the 15. Quilivant, convert the total methylene daily dose to once a day Quilivant dose. Easy. Guanfacine, we just talked about, start with those low doses, add a second, third dose. FDA recommended maximum daily dose is 0.012 milligrams per kilogram. I would try not to go over that very much. Next slide. And that's it about medicines. So for positive incomes, I think we would both say, right, Amy, emphasize and support the child's strengths, emphasize functional outcomes, continue treatment as long as needed, treat comorbid disorders, educate regarding natural history, and activity and impulsivity will decrease with age. That's the big positive you can deliver right away. And be positive because treatments work and most children have good outcomes. And please give us a call if you want to fuss with us about this. I don't know, do we have time for a little discussion or questions?
Yes, thank you so much, both Dr. Benincourt and Dr. Riddle, for that wonderful presentation. We can open it up now for any questions. So if anyone has one, please place it into the chat. Oh, I just had one sent to me, and it's, what are your thoughts about patients not taking their ADHD medication on the weekends?
Thoughts about not taking their medication on weekends? Well, I'm a big believer, and I think most prescribers are big believers in holidays. And so if it's a weekend, winter break, spring break, over the summer, if the child can do okay without the medication because the demands of school aren't there, then do it. If they can't handle it, then probably continue it. And I recommend always considering stopping the medication after there's been a year of things going well, and then do that annually. And it may be that in trying to stop it, you'll find that a lower dose will still get the job done. So I think that's it.
You'll see in the chat that Grace put the link for the evaluation survey for today's session. So please take that if you would like to receive CME or CEU credit.
But I saw that one pop up and it went away.
This one says male with ADHD and small due to malnourishment possibly needs to go on growth hormone. Recommendation for medication.
Well, the stimulants are obviously going to be a big worry, right? Because of appetite suppression. I would work with I assume it'll be a pediatric endocrinologist who's doing the growth hormone treatment. I would want to work with that colleague, and I would probably lean toward, if I felt I had to use medicine, ronfacine.
Looks like we have another question. I know you mentioned there are no validated assessments for ADHD for the preschool age. Do you still recommend using one to aid in your diagnosis?
Yeah. So I'll say the answer of what I do, and this is my opinion, so nobody can come for me about this, but I still will frequently use the Vanderbilt with the parent, mostly as a decision point of making sure that we're walking through and assessing the symptoms, but knowing that, I need to have an eye for what's developmentally inappropriate. So you really have to be careful, but I will use that frequently as a starting place. The other thing is, if you're in a place where your clinic is willing to pay for assessment tools, there are some avenues that opens up. So there's the child behavior checklist, which goes down to young children. It's one of the very few, I think, validated forms that really kind of gets into these symptoms. So you could use something like that. But I will definitely confess that I do use the Vanderbilt clinically, even with young kids who are on that borderline range. I don't know, Mark, if you want to add anything.
Yeah, I would agree completely. And it's very educational for the parents. They'll learn from it.
Yep.
Great. And it looks like we have one more question. What do you recommend families do with children who have a PTSD diagnosis as it relates to difficulties with focus and attention?
I'll make a comment here. So maybe we should have said something about PTSD, because it's pretty common. It affects young kids. I would say that the focus attention stuff is more likely due to anxiety, but it could also be ADHD. And the key to that is the ADHD distractibility is focused on what's happening externally, things you hear, other things going on in your preschool. You just can't tune them out. Anxiety is within. Now, you can't, your thoughts, worries, ideas within. You can't really talk to a preschooler about that, but it's still worth having that concept in mind.
I think the other thing I'll add is that some of the components of parenting skills programs for young kids would still be helpful for a kid who's dealing with trauma. So if you think about routines and that child-centered time and even praise, these things are going to be helpful to them, even if the diagnosis is more of an anxiety or PTSD type diagnosis than an ADHD diagnosis. And we know for kids who've experienced trauma, routines in particular, kind of making sure that there's safety and predictability is going to be key. So Mark's right that we have to be thinking about the kind of range of other diagnoses that might be playing a role and the comorbidities, because we know that how the rates of adverse childhood experiences are high, and so maybe comorbid with lots of these things, even if the child does not meet full criteria for a PTSD diagnosis.
Okay. Thank you again for this wonderful presentation, Dr. Benincourt and Dr. Riddle, and to our participants of today's session. The recording for today's session, the slides, and a list of related resources will be available on our website next week. We will send CME and CEU certificates to our participants in 3 business days. Please remember to take the survey as you leave, because this is required if you'd like to receive CME or CEU certificates. And stay tuned for future BHIPP resilience breaks and other BHIPP trainings by following us on LinkedIn, Facebook, and Twitter. And thank you so much again, and I hope everyone has a great rest of their day.
Bye-bye.